Today we're going to be talking about the thigh. Last lecture we talked about the pelvis and the different bones and the structures over there. We talked about the development of the limbs. What else did we talk about last time? Let's see. Did we touch upon muscles? No, we didn't get to the muscles, but we started touching upon the different nerves that exit the lumbosacral plexus, which was a pretty heavy slide, but you'll start to see why I want to talk about the lumbosacral plexus, because I'm going to be relating a lot of the nerves to the musculature in the thigh. So yeah. All right, I think we'll get started now. And then whoever comes in, I'll just add them as we speak. Alrighty, so let's get started. We haven't really talked about movements in the lower extremities yet, but like we talked about with the upper extremity, the lower extremity is very similar in the sense that you can kind of compare the hip to the shoulder, the knee to the elbow, and the ankle to the wrist in terms of how things operate, right? There were some few inherent differences, but altogether, movement-wise, it's pretty similar. So if we were to compare the hip to, let's say, the shoulder, what I want you guys to kind of answer me with right now for my question is, what kind of movements do you think the hip can do? Can you guys label all the movements? And I got a bunch of them on this slide right now, but let's see if you guys can label some of the movements. I'm looking for 6 movements. So what are you guys thinking for movements of the hip? Yep, flexion, extension. You got it, Penny? What else? Abduction, adduction. Beautiful. Good on you for capitalizing the AD and AB, because that could often get confusing. Circumduction. That's an interesting one. I'm not sure. I know the shoulder can circumduct. I've never actually thought of the hip as a circumductor. So let's ask Professor Google. Yeah. Yep. The hip does circumduct, so you're absolutely right, Tara. Internal and external rotation. Perfect. All right, so you guys got it. So hinging at the hip, we normally refer to hinging as flexion or extension. For your question, Teresa. So we use the hip hinge a lot when we do something like the deadlift or the squat. Both require hip extension and flexion primarily. With the squat, we do get a little bit of rotation as well, as the knees tend to go outwards or inwards if you do the squat, a little bit incorrectly. All right. So you guys are awesome as usual. You guys got all the answers. And it even gave me an extra one that I wasn't even thinking about. So awesome. So yeah, the hip can flex, extend, internally rotate, externally rotate. It could also adduct and abduct, right? So if you guys look at the diagram over here, you see this gentleman doing 2 things. He is flexing his hip as well as extending his knee. And I didn't really ask about the knee because the knee's pretty obvious. Although there is one thing that you guys might not be aware of with the knee, but the knee pretty much flexes and extends, kind of like what the elbow does, right? So this gentleman over here is flexing his hip, extending his knee. I just realized this lady is naked. Sorry about that. This hip over here is flexing. This one's flexing, 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 flexing. So these are all hips flexing in different degrees of motion, right? So this hip's flexing at 90 degrees. This one's flexing at 120. This one's flexing at the maximum. We say the maximum hip flexion we get is 135 degrees. One of the things that can limit hip flexion is soft tissue approximation, meaning the thigh gets really close to the abs and you can't really flex it anymore. But you can flex your hip with both a bent knee and a straight knee. And then over here in the squat, we have a prime example of a compound movement where to get down in a squat, we have to flex our hip eccentrically, we gotta flex our knee eccentrically, and we gotta dorsiflex our ankle. And we're gonna talk about ankle movements later on. But then concentrically, when we have to get up from a squat, we gotta do the opposite. Now we gotta plantar flex at our ankle, we gotta extend our knee, and then we gotta extend our hip. All right. And this gentleman over here is doing a poor example of hip extension where he's getting that leg to go backwards, right? But the reason why I say it's a poor example of hip extension is because his trunk is also moving forward. So he's actually flexing his standing hip. So is he really extending his right leg, or is he just flexing his, sorry, is he really extending his right leg, or is he really just flexing his left leg is what I'm hinting at with that one. So you got to be careful too, right? And a lot of times when we kind of give exercises, if we are trainers or physios or yoga or Pilates instructors, we got to be careful with form. And if we were to tell someone to stand and do a hip extension, this wouldn't, this wouldn't be proper. You'd have to get them to stand upright and make sure that the only thing that's moving is their hip. But this is presumably hip extension. And then you got this figure over here. So you got this person lying down on their side, and with their left leg, they are lifting up to cause hip abduction. And then eccentrically on the way down, they're causing hip adduction, adduction. Okay, so those are all the general movements. Now I said the knee can be a little bit confusing, and that's because when the knee is bent at 90 degrees, it could also rotate. So people don't often think of the knee as a rotator, but what I want you guys to do when you get a chance after the lecture is done is try to find a seat where your feet are dangling. So sit down on a surface where it's a little bit taller to the point where you can't touch your feet on the floor, and then try to rotate your foot to the right and to the left. When you're doing that, you're actually rotating your knee. Okay. Now, knee rotation is something that we don't try to strengthen in isolation. It's more so something that just happens to allow us to do other movements. It's called an accessory movement. So we don't try to strengthen our knee rotation in the gym. We try to strengthen our knee extension and flexion, but not a rotation. Now, here's the interesting thing about the knee, guys. When your knee is fully extended, meaning when your knee is straight, like this individual over here with a standing knee, you actually cannot rotate your knee anymore. Okay, so that's something interesting about the knee. It is able to rotate when it's bent at 90 degrees, but it's not able to rotate when it's fully extended. Okay, so let's talk about the superficial aspects of the lower limb first. And one thing that's pretty unique about the leg is that it has a lot of dense fascia. Okay, remember we talked about fascia as being this really dense connective tissue that functions for a few reasons, right? It functions as something that groups things together. So it groups all the muscles together, making sure they don't, go out of place or pop out of place. Now, this is directly underneath the skin of our lower limb, okay? We don't have the extent of this kind of fascia in our arm. So the legs actually have way more density to the fascia than the upper limbs. And one of the main reasons why is that there's more mass in your legs, right? But there's also a lot more force from gravity exerted on the legs. So the blood flow has to travel, against gravity to get to the heart. So you can imagine why you need a lot of dense fascia here to kind of keep everything bound up, right? So this tight fascia kind of keeps the blood supply to the limb at a required rate. It's also important for keeping the legs tight. We don't want the legs to be too loose, but this fascia does get looser as we age as well. And then what you have over here is a saphenous opening. So what that is a small little gap in the fascia, which allows some blood, some veins, not arteries, veins to kind of enter. IT is iliac crest to tibia. You got it. Yes, Tara. So IT is an acronym, right? I refers to ilio, T refers to tibial, so IT band. So Ilio meaning iliac crest, exactly. All right, I lost my mouse there. So that's why we kind of have this really dense fascia there, right? Now, if you look at here, again, we're talking about the saphenous opening. We'll never have an artery that's superficial on the leg. So we'll only have a vein that's superficial. And the vein has to enter at some point, and that's where this opening is. So the vein can't go through this dense fascia, so the body created a way for the vein to enter over here in the saphenous opening. Now, let me ask you guys a question. Why do you think that we can never have, arteries superficially? We have a lot of superficial veins, right? So, for example, if you were to like work your biceps and you get a nice little bicep pump, for all my bodybuilding guys, you'll sometimes see a vein popping out or veins popping out of your head, right? But why do we never see an artery that's superficial? We always see veins superficial. Too dangerous if it gets ruptured. You're absolutely right. So I guess my next question, Tara, and for the rest of you guys is why is it too dangerous? So it is too dangerous. Why? I don't think I've touched upon this yet. Maybe earlier on. Just gonna pick your guys' brains for a second. Why is it? Melanie, I love that answer. Bleeds more voraciously. Because it is more blood flow to and from heart. You would bleed out. Blood pumps from heart through arteries. You guys are right. So the arteries, if you were to nick an artery, you'd start bleeding profusely. The reason being is that the arteries have a much higher pressure to them than veins do. Veins are a low pressure system, right? They collect blood that pools at the extremities and brings it back to the heart, right? But arteries are a high pressure system, which starts at the heart and has to pump to the rest of the body to supply oxygen and nutrients to the muscles, for the muscles to act, right? The oxygen is the energy for the muscles to act. So that's why you never ever see arteries superficial on the body. You only see veins. The body's very smart. It's always going to try to protect us. Good job, guys. Really good answers. Okay, so let's talk more about this iliotibial band that you see over here on the lateral side of your hip. Everyone's heard of the IT band. It's on the lateral side between the ilium at the iliac crest, like Tara said, all the way to the lateral aspect of the tibia bone. Okay, it's a band of fascia that often gets really tight, especially in runners. Runners tend to have what is known as IT band syndrome. IT band syndrome often leads to pain in the knee, and that's because of the IT band's influence on the knee. Okay. If you look a little bit higher up over here, so over here, the left diagram is an anterior view of our leg. If you look at the right diagram, we actually see a lateral view of the leg, and you can see the extent of that iliotibial band over here. Okay, and the iliotibial band is actually superficial to that fascia that I was just talking about. So that fascia is called fascia lata. It's just all that covering that you see over here. I didn't mention that before, but it is called fascia lata. And then superficial to that fascia lata, you got this band of this IT band, which is a really thick band of tissue. Now, if you've ever had the privilege of being able to dissect a cadaver, you'll notice that when you pull at this IT band, it's really tough. And so one common misconception I hear from a lot of people, especially in the rehab world, is that you can roll out your IT band. This is actually false. What you're doing, like to be able to influence the elasticity or the pliability IT band, you would require a lot more force than a roller. And I'm saying this from firsthand, actually pulling on an IT band and thinking, man, this thing's not moving. Right? So whenever you roll the outside of your leg using, let's say, a foam roller, you're actually trying to influence the muscles underneath it. And we're going to be talking about that in a bit, but this is just kind of a way for me to describe that you can't really roll out fascia, right? We can influence the fascia by influencing the muscle underneath the fascia, but fascia itself is really tight. It's really strong, and it's supposed to be, right? So I figured that was something interesting. And then over here on the lateral view, you can see the gluteus maximus, which is the most superficial butt muscle, so to speak. We got the tensor fascia latae, which is a small muscle in the anterior proximal lateral portion of the hip. We're going to be talking about that in a bit. And then, like Tara mentioned, the iliac crest over here. And that's where that IT band originates from. And then we got the tibia down here. You can see that IT band's attachment to the tibia. And then don't worry about this just yet. This is called extensor retinaculum of the foot. We're going to be talking about that in later lectures. All right, let's get through the veins. We have just a couple main veins in the leg, but I think it's important to talk about because we often see more dysfunction in the veins in the lower extremities than the upper extremities, particularly in certain populations. So just a quick review about the veins, guys. We always start with the distalmost portion when we talk about where the veins start from, right? So when you look up here, the femoral vein, the deep vein that goes through that, deep to that saphenous opening, that's not the start of the vein, right? We talk about the start being at these smaller veins over here, right? The veins start at the very distal portion and they start moving up towards the heart. So there's that directionality towards the veins, whereas the artery starts from the heart and goes towards the extremities, okay? So just keep that in mind. Now, because there's a lot of skin on the lower extremities, especially in the thighs, we need a large vein that's going to help return a lot of the blood back to the heart from areas around the skin over here. And that's why we have this great saphenous vein. It's really big. It comes from that, well, it enters that saphenous opening over here, and it kind of takes all that blood that is superficial over here near the skin and brings it towards that saphenous opening over here and shunts it towards the heart. So this is all superficial. And if you guys were to ever see something called varicose veins, you'd probably be looking at either the great saphenous vein or the short, small saphenous vein. These are both, so the great saphenous and the short saphenous vein, these are both veins that are superficial to the legs. Now, varicose veins, why does varicose veins even happen? It's a couple of reasons. It's usually poor blood flow and distension, meaning just like a shunt, leading to valve failure. So remember, guys, veins, they have valves, right, to prevent backflow of fluids, right? Because veins are a very low pressure system, right? So, for example, if you were to start over here and these veins have to bring blood all the way back up to the heart, it has to have some sort of pressure to push it up, right? But we know that the veins are a low pressure system. So what it relies on is the muscles to contract and squeeze it up, right? So we rely on the muscles of the calves, the muscles of the shin, the muscles of the thighs to operate and squeeze the blood up towards the heart. Now, we're not always using our muscles. So if, let's say, the vein were to squeeze it up, right, but then we stop using our muscle, is it going to fall back down? And the answer is no. We have we have valves that prevent blood flow from happening. So if we were to get blood flow up and then you would stop moving, it would stay stuck there. It wouldn't go back down, okay? But with varicose veins, what happens is these valves don't operate properly and the blood starts getting, stuck and you're getting a bunch of distension. So you're getting, the veins start to swell up a little bit and they become dysfunctional. That's why you see varicose veins. And for anyone who doesn't know what varicose veins are, it's pretty much the veins that stick out of the veins that stick out of the skin that you sometimes see in people, especially their lower extremity. And you're wondering, wow, why do they have all these veins sticking out? Well, that's why. So you got that great saphenous vein over here. You got the short, small saphenous vein. So the short, small saphenous vein actually dumps into this popliteal vein. And for reference sake, the popliteal region of the knee is the back of the knee, just for your reference, guys. So the short, small saphenous vein actually dumps into this popliteal vein, which is a deeper vein that eventually dumps into this femoral vein over here. Okay. Okay. So I always like to throw a cross-section slide just to like throw things off, but I feel like whenever I look at a cross-section, it kind of reaffirms what I've learned about a certain part of the anatomy. So what we're looking at right here, guys, is a cross-section of your thigh. And when you look at a cross-section of your thigh, you can actually see 3 different functional compartments, okay? And if you guys remember a thing or two about compartments, you'll remember that compartments are often separated by bands of fascia. And if you look at the diagram here, the compartments are actually, colored differently. So we'll start with the anterior compartment. And we got the muscles over here that are in a deep red. And these consist of all the thigh muscles that help either extend the knee or flex the hip. Okay, so these muscles, once again, flex the knee, meaning they straighten the knee when they contract, and some of them even flex the hip when they contract. Okay, and then we have the medial compartment, right? And the medial compartment are the group of muscles that sit near the groin and along the inside of your thigh. And these muscles are involved in one movement and one movement only, and it's to adduct the thighs. So bringing your thigh back to midline. And we also call them the adductor groups because of the movement. Okay. And the last compartment of the thigh is the posterior compartment. And this comprises of muscles that both flex the knee, so bend the knee, as well as extend the hip or get that thigh moving backwards. And you guys are fully aware of the hamstrings. So those are the group of muscles that sit behind or posterior to the thigh. Okay, so those are the main compartments of the thigh. So we're in a really busy slide over here, but just take a deep breath. It's not super complicated if you just slow things down. We're looking at the anterior view of the left thigh. And I know it's the left thigh because all these muscles sit in the front. And if you were to orient yourself, if this is the front of the thigh muscles, if you're not looking at the hamstrings here, you know that. Good job, Mia. I'm glad you took a deep breath. You know that we're looking at the left thigh. So let's start from over here. And we got muscles that actually sit atop of the inguinal ligament. So we're going to use the inguinal ligament over here as a reference point. If you guys remember from the lecture before, we talked about how the inguinal ligament attaches from the iliac crest, the top of the iliac crest, so the ASIS, all the way to the pubic area over here. I'm just going to add participant. So inguinal ligament from the ASIS all the way to the pubic tubercle over here. And it created that false pelvic circle. But remember, we also had that true pelvic circle, which was a little bit deeper. But anyways, we have that inguinal ligament over here, just as a reference point, okay? So above it, we have this huge muscle called the psoas. A lot of you may have heard of the psoas. It's quite a big muscle. It's often implicated in low back pain, and you can kind of see why, right? So it's this red muscle over here, and it has multiple attachments to the lumbar spine. So it attaches at it attaches at the level of L4, L5, and sometimes L3. That's where it originates from. And on the way down, you can also see a muscle to the right of it called the iliacus. So the iliacus has an interesting name, but it's a helpful name because it originates from the iliac crest, as you can see over here, the iliac crest. All right, so you got these two muscles that sit kind of deep to all these muscles of the thigh. And as they run distally, they actually unite and become one muscle called the iliopsoas. towards the end. Okay, and you don't see it, but they dive deep underneath these muscles and attach to the lesser trochanter of the femur. And I realize I did not teach you guys about the lesser and greater trochanter of the femur, which is not good. So I'll have to make a note of that. But just like we had the greater and lesser tubercle of the humerus, if you guys remember from the arm lectures, that's analogous to the greater trochanter and lesser trochanter of the femur. So what I'll do is I'll add a few more slides for the next lecture talking about the osteology of the femur in a little bit more detail. I don't think I touched upon the trochanter though. I'm just gonna double check real quick, guys. Nope, I did not talk about the greater and lesser trochanter, so I will be talking about that in the next lecture, I promise. All right, so now we got the psoas, the iliacus, and it dives deep and unites as an iliopsoas and attaches deep into the lesser trochanter of the femur. And it's a very powerful hip flexor. In fact, it's probably the most powerful hip flexor we have. Okay. Now, let's move a little bit more distal or inferior to that, and we'll start with this muscle over here, this really long muscle that starts laterally on the hip and crosses towards the knee medially. Okay. And it's called the sartorius. And fun fact about this muscle, it's the longest muscle of the human body. And you could tell by the path why that could be the case. It begins at the ASIS, so the anterior superior iliac spine over here, that nice bony bump of the iliac crest. And what it does is it crosses both the hip joint, which is over here, as well as the knee joint. So it's a two-joint muscle. It's a pretty complex muscle because of the way it crosses from lateral to medial. And then it goes all the way down and attaches to the tibia via a structure called the pens anserinus. So I'm gonna write that for you guys because I don't think I put it in here. Just make sure I spell it properly. Pens anserinus. So here's my homework for you. Google it when you get the chance. So the pens anserinus, it translates into the goose foot. It's pretty much the joining of three separate tendons from three muscles that insert onto the medial aspect of your tibia. Okay, so sometimes what muscles will do is they'll unite as one tendon, and you're going to see that actually with the thigh a lot. You'll have multiple muscles, but then they turn into one tendon and attach to the bone like that. So just keep that in mind. But yeah, make sure you take a look at that, and then I'll kind of ask you guys what you thought of it and what other muscles are attached to the pes anserine later on. Okay. So this muscle, because it crosses the hip anteriorly, it flexes the hip. And if you were to imagine it contracting, it also laterally rotates the thigh. So the sartorius also externally or laterally rotates the hip. And it's a muscle that contracts when you sit and cross-legged. So when you sit cross-legged, you have to flex and externally rotate your hips. So anytime you sit cross-legged, think of yourself using your sartorius muscle. It's a really weird muscle. Okay, and then we got the muscles of the quads. Okay, we got rectus femoris, which is the one down the middle over here. We got vastus lateralis, which is the lateral muscle over here, and we got the vastus medialis, which is the muscle over here. And the names kind of give you a bit of a hint as to what they do. The femoris tells you it's along the femur, of course. Lateralis, so this is the more lateral muscle of the thigh, and then medialis, more medial. Okay, but as you guys know, quad doesn't mean 3, it means 4. So what we're not seeing is the fourth quad muscle in this slide, and that's fine. Let's go through the ones that we see so far, okay? So we'll start with the rectus femoris, and it's a muscle that crosses two joints. So a muscle that crosses a joint influences the joint, meaning if it crosses the hip, it will influence the hip. If it crosses the knee, it will influence the knee. So it influences both, right? So it arises from the AIIS, the anterior inferior iliac spine, which is just inferior to the ASIS. So it's just right over here. It arises from there, and it courses along the thigh anteriorly and merges into this quadriceps tendon over here. Now, it probably shouldn't be colored this color. Just think of this as like a white color over here. I think another slide down the road will help with that as well. Oops. All right, so because of its attachments, the rectus femoris will flex the hip and extend the knee. So it does both, guys, okay? And it's unique to the rest of the quad muscles because it's the only muscle of the quads that crosses the two joints. The rest of the quad muscles originate from the femur, so it doesn't cross the hip, but the rest of them influence the knee, okay? So next one I want to talk about is the vastus medialis, and it has kind of like that teardrop shape. You'll see it very profusely on bodybuilders. It's on the low medial side. It's a really bulky muscle over here, and it too attaches to the quad tendon over here. And then on the outside, you get the vastus lateralis. It's more, and you can see that it's kind of in line with the iliotibial band that would be on the outside of these muscles over here. And that also attaches to the quadriceps tendon over here. And then you got this weird muscle on the very lateralmost aspect over here. And that's a tensor fasciae lata. Based on its name, you can see that it does influence the fascia lata. Tensor meaning it probably tenses that fascia lata, right? So this muscle is actually continuous with your IT band. And because of that, it's often implicated in problems with the IT band. Okay? So just keep that in mind for now. So we're going to take a quick look at these muscles in isolation. So we got that Sartorius muscle over here, and then we got the tensor fasciae lata over here as well, without any of those other thigh muscles. And kind of what I indicated before, just think of the Sartorius as that sitting muscle. So because it flexes and abducts and laterally rotates the thigh, it puts you in this position over here. But it also flexes the knee joint because it crosses the knee. Okay. And the tensor fasciae lata over here, it's a relatively small muscle, guys, but it is continuous with the iliotibial band. It's a really weak hip flexor. It also internally rotates the hip, and it's a weak abductor of the hip. And it's a muscle that tends to get really tight, especially if you spend a lot of time sitting. And it's a muscle that I often, try to release whenever I get one of my guys that are, lacking hip internal rotation or just really tight when they sit. So this is one that's often implicated in hip pathology, that tensor fasciae lata, very annoying muscle. And I forgot to mention in this slide, all these muscles for the most part are innervated by the femoral nerve. So if you guys remember femoral nerve from the last lecture, we talked about it originating from nerve roots L2, 3, 4. And the thing that we use to remember the femoral nerve and its actions, or where it innervates, is that L2, 3, 4 kicks the door. So all the muscles that are involved in kicking the door are innervated by the femoral nerve. Okay, I think I'll have to make this the last slide, guys, and I'll have to leave a little bit early, so my apologies about that. But let's get through this. Let's see if I can finish it all. Now what we're going to do is we're going to look at the quad muscles in isolation, right? So we've moved all the other muscles out of the way, and once again, you can see that the rectus femoris originates now from that anterior inferior iliac spine, courses along the entire thigh, and attaches to that quad tendon right over here, right? It has the two movements, so it flexes the hip and it extends the knee because it crosses the two joints. You got the vastus lateralis over here, outside of the thigh. It originates from the femur, so it doesn't cross the hip. It's often implicated with IT band syndrome because of how, how close it is to the IT band. So it's often tight. This is the muscle that we're trying to roll out whenever we use a roller, the vastus lateralis. So we're never trying to roll out the IT band like I mentioned before. We're actually trying to influence this vastus lateralis. So this is the muscle that sits at the side of your thigh. Okay. And then we got that vastus medialis. And so all these three muscles kind of, go into this quad tendon over here. And this quad tendon eventually attaches to your patellar bone or your kneecap. Okay. Now the quad is 4 muscles. So if we move all these superficial muscles out of the way, you'll actually see the 4th quad muscle. And that's called the vastus intermedius. And it's deep to the rectus femoris. This muscle also goes into the quadriceps tendon over here, which attaches to the patella or the kneecap. And since it doesn't cross the hip joint, so the hip joint's over here, guys. Since it doesn't cross the hip joint, it doesn't influence the hip joint, so it also it extends the knee when it contracts. Okay. So you'll notice that all these 4 muscles eventually terminate onto that patella over here. And we call it the quadriceps tendon here. But if you look below the patella, we get the patella attaching to the tibia. Okay, and you guys may have heard terms like the patellar tendon, but from what I've learned in my experience, there actually isn't a patellar tendon. You can call this over here above the patella a patellar tendon technically. I refer to it as a quadriceps tendon, but this tissue over here is erroneously called the patellar tendon. And the reason being is that a tendon is something that attaches a muscle to a bone. So to be a tendon, you have to be something that attaches a muscle to a bone. Whereas a ligament attaches a bone, your kneecap, to another bone, which is the tibial tuberosity of your tibia. Meaning this is the patellar ligament. It's not the patellar tendon. Okay, so just trying to remove the confusion about that tendon, nip it at the butt. Make sure you guys never call that the patellar tendon. So I think we'll end off there, guys. Once again, sorry for the smaller lecture today. I found out last second that I'd have to leave early. What we're also going to talk about, so I'm going to talk about the femur bone in a little bit more detail next lecture. I'm going to add a few slides about that. What I also want to do is talk about the difference between ligaments and tendons. I never got a chance to really touch upon that, so I think that would be something interesting to talk about because there are inherent differences between tendons and ligaments. We already talked about one of them, so tendons are something that attach muscle to bone. Ligaments are something that attach bone to bone, right? But I think it's important for your knowledge to know the difference beyond just that because there are a lot of differences as well, and they relate back to function too. So I'll add that to the next lecture slides, and let's see what we're doing for next lecture. Next lecture, we're going to be getting into the posterior thigh. So today we were talking about the anterior thigh. Next lecture, we're going to continue. We're going to talk about the adductor, so the medial thigh. We're going to talk about the femoral nerve and the triangle a bit more. And then we're also going to talk about the posterior thigh next lecture, okay? So thank you guys so much for tuning in. Sorry again for that small lecture.